Tokyolive Endoscopy 1.
Hello, everybody. I'm Hironori Yamamoto from Jichi Medical University, and I will moderate this session. This session is tips and tricks for balloon-assisted enteroscopy, and we have two speakers. The first speaker is Professor Kazuo Otsuka, and he will give us talk about assessment and treatment of inflammatory bowel disease. I'd like to introduce briefly Professor Otsuka. Professor Otsuka is a professor at the Tokyo Medical and Dental University and chairman of endoscopy at the University Hospital of Tokyo Medical and Dental University in Tokyo, Japan. Professor Otsuka graduated from Niigata University School of Medicine in 1988. He completed residency in internal medicine at Akita Red Cross Hospital, and he completed the Niigata University Graduate School in 1995. After obtaining a doctorate degree, he advanced research at University of Southern California and received the 18th Annual American College of Rheumatology Senior Rheumatology Scholar Awards. After returning to Japan, he worked as the faculty at Showa University Northern Yokohama Hospital for 11 years. During this time, he participated in the development of capsule endoscopy and single balloon endoscopy. He developed the single operator method of single balloon endoscopy. In 2012, he has moved to Tokyo Medical and Dental University and focused on endoscopic diagnosis and treatment of inflammatory bowel disease. He recently reported the importance of balloon-assisted endoscopy for detecting small bowel stenosis in Crohn's disease and the relation of endoscopic findings and prognosis of Crohn's disease. Okay, Professor Otsuka, could you start your presentation, please? Lecture, please.
Okay, thank you. Ladies and colleagues, thank you for the kind introduction, Professor Yamamoto, and I'm Kazuo Otsuka from Tokyo Medical and Dental University. Today, I talk about assessment and treatment of inflammatory bowel disease. This is my COI. These are today's topics. First, introduction, then endoscopy, assessment and assistant, and endoscopic therapy for IBD. I will talk about them. At first, introduction. What is the purpose for IBD therapy? There are two steps. One is the induction. The most important for patients is that there are no symptoms. Patients want normal quality of life. After achievement of induction, maintenance is important. That is no recurrence and also no admission. Treat-to-target strategy is advocated. This is based on regular assessment of disease activity by using objective clinical and biological outcome measures and the subsequent adjustment of treatment. Recently, the treat-to-target strategy is revised. Detailed targets are proposed. As for short-term, therapeutic therapy is a symptomatic response. Then symptomatic remission and normalization of CRP is advocated. For the intermediate targets, decrease in calprotectin to assess acceptable range and normal growth in children in special cases. And as for long-term targets, endoscopic healing, normalized quality of life, and absence of disability. And as for Crohn's disease, transmural healing is important. And ulcerative colitis, histological healing. One question is that clinical symptoms reflect endoscopic feeling or not. Meta-analysis of clinical trials show that no symptoms does not mean endoscopic healing. There are endoscopic activity in patients with CD, only 20 to 30% of patients are achieved endoscopic hearing. So next topic is about for the enteroscopy. They are typical findings of Crohn's disease. When longitudinal ulcer or cobblestone appearance is confirmed, the patient is diagnosed as definitive Crohn's disease by Japanese criteria. So endoscopy is very important for diagnosing inflammatory bowel disease. Actually, most of inflammatory bowel disease are diagnosed by ileocolonoscopy, but entire GI tract is affected in Crohn's disease. Therefore, we need to examination of small intestine. They are the longitudinal lining ulcers in the ileum. These ulcers are early stage of longitudinal ulcer. And these pictures are from different patients, but longitudinal lining ulcers connected, and then finally they form longitudinal ulcer. During endoscopy, endoscopists should be careful for mucosal injury and perforation. In many cases with CD, fibrosis and hardening occurred in the mesenteric tissues. And as a result of inflammation, sometimes adhesion occurred. When some resistance are felt during endoscopic maneuvers, fluoroscopy is helpful. Fluoroscopy shows adhesion. Endoscopy showed small dent. This was the adhesion site. As for assessment, scoring is important. SCS-CD is often used as endoscopic score for Crohn's disease. But the score is segmented intestine as ileum, right colon, transverse colon, left colon, and rectum. So small bowel is much longer than colon. I think small intestine is underestimated in this score. So we propose detailed segmentation for small intestine. So this applied SCS-CD segments segmented as terminal ileum, proximal ileum, and jejunum. There is a clinical question. Does evaluation of small intestinal lesions predict prognosis or not? We assessed the clinical and serological remitted ileal or ileocolon type of Crohn's disease 139 patients. These patients are looked at in remission. But by endoscopy, 45% of patients are active. Endoscopic hearing, it includes not only non-mucosal activity, but bowel disease such as erosive regions. They are the 76 patients. But 63 patients, so 45 patients, have significant active lesions such as longitudinal ulcer. After 1 year, 30% of patients with endoscopic active lesions were relapsed. Contrary, there were no clinical recurrence among endoscopic healing group patients. Of course, longer follow-up, some patients were recurred, but clinical and serological remitted, but endoscopic active patients returned more. So endoscopy can predict the recurrence of Crohn's disease. So assessment by endoscopy is important, I think. Last February, new single bowel endoscopy is released. It has a 3.2 millimeter diameter channel. It helps smooth insertion of catheter. It is equipped with passive bending. It will help insertion for the intestine with depending, such as Crohn's disease. Next topic is AI-assisted endoscopy. So it will help assessment and it may assist assessment. So AI-assisted endoscopy for ulcerative colitis is now available. This video is from Dr. Ogata and Maeda of Showa University, Northern Yokohama Hospital. Firstly, change to NPI mode and contact the region or mucosa, then at the magnification observation is confirmed. This is remitted cases. After using endocytoscopy, it confirmed healing. This scan system had 74% of sensitivity, and as for specificity, 97%. And this is Tokyo Medical and Dental University developed our AI system, DMUC, for ulcerative colitis. Each images are assessed and output UCEIS score. This is a famous ulcerative colitis score, and also endoscopic remission, and yes or not. And this system also reports histological assessment. It achieved 91.1% accuracy for and 92.9% accuracy for predicting histological remission. This system can predict the prognosis. Mucosal active group assessed by DNUC, around 40% of patients were recurred within a year. And as for predicting colectomy, almost similar results are available compared with expert endoscopists and DNUC AI system. AI has many possibilities. One is for the clinical trials. The other is providing training for the beginner or very younger endoscopists. And of course, AI will help decrease the fee of the biopsy and other costs. And now we are living in an era with AI. So AI diagnosis will become more popular, I think, especially for the assistant for diagnosis and assessment. But big data is necessary, and AI is weak for rare diseases because it needs big data. So as for common disease, maybe AI is very, very useful. So, and only doctor can manipulate endoscope. So endoscopist is indispensable. Still, in the era with AI. Final topic is Endospect Therapy for IBD. Crohn's disease has two aspects. That is, one is a frequent recurrence of the inflammation. The other is accumulation of digestive damages. Recently, MR enterography is used for assessment of Crohn's disease. MR enterography can assess inflammation very well. However, as for stenosis, MRE is not enough. This table shows diagnostic accuracy of MR endoscopy for intestinal damage compared with endoscopy. Only 60% of severe stenosis were detected by MR enterography. Therefore, endoscopy is necessary for the assessment of intestinal damages. Half of the reason of surgery for the Crohn's disease are stenosis. To avoid surgery, endoscopic balloon dilatation is available. So if there's a stenosis, then insert a guide wire. Then insert a balloon dilator. Inflate the dilator. Now scope can be passed like this. This is a strategy for strictures of Crohn's disease in small intestine. If there's a strictures in the small intestine, first assessment of are there any abscess or fistula? If abscess or fistula exists, in that case, this is an indication of the surgery. And the stricture length is next important. If the length is more than 5 centimeters, in that case, unfortunately, they go to the surgery. And without deep ulcer, in that case, endoscopic balloon dilation is available. This is a national data for endoscopic balloon dilation for small intestinal stricture. EBD helps decreasing abdominal pain, bloating, and nausea. This is a recent Japanese multi-center study for the EBD. They also showed EBD is helpful for avoiding surgery. And the recent meta-analysis shows a risk factor for EBD, because Crohn's disease is persistent inflammation. So in many cases, re-EBD is needed. And the risk factor is Asian, and jejunal or proximal ileum stricture are risk factor of re-EBD. This is a Crohn's disease case. This patient was performed capsule endoscopy, and it is diagnosed as Crohn's disease. But unfortunately, capsule was retained. So by the retrograde approach, there's many strictures after 4 dilation. Then finally, yellow-colored capsule was detected like this. Using net, capsule was retrieved. So this patient can avoid it surgery. This is a final slide. Today I talk about the treat-to-target strategy, and then importance of the enteroscopy. Do not forget small intestine. And the progress of AI also presented. And finally, I show endoscopic balloon dilation. Thank you for attention.
Thank you. Thank you very much, Professor Otsuka. Yeah, very nice talk. And I have 2 questions. One is, what is your interpretation when the endoscopic balloon dilation becomes necessary? What do you think? That's a failure of the first. Do you think that is a failure of the first dilation? What is your interpretation when balloon dilation becomes necessary again after
the reason of the redirection? One is persistent information is very important. If there's information, in many cases, stenosis occurred.
Yes. So is that a failure of the first dilation?
No, actually, no. It depends on the interval. If the patient needs EBD within 6 months, maybe it's an indication for the surgery. But but it lasts around 1 year. So I think annual EBD is acceptable for the patients, I think.
Yes, I agree.
Because Crohn's disease is recurrent, and in many cases, surgery is not so good.
We want
after
to
surgery.
avoid
After the surgery
syndrome.
Yeah, and also after the surgery, endoscopy is very, very difficult. So as for endoscopies, surgery is not. I don't like surgery.
Yes, and even after surgical resection, we have recurrence of the inflammation in Crohn's disease patients. So it's not a curative treatment, even with surgical resection. So I agree. If the balloon dilation is necessary once a year, that is a kind of maintenance therapy. So it's not a failure.
Right.
I agree.
I agree.
Yeah, and the next question is, when you start new treatment such as infliximab or other kind of biologics, and what is the timing of the enteroscopy, balloon endoscopy you perform?
One is before the start of the biological therapies. And next is, and second is after the surgery.
Surgery?
After the surgery case, as for surgery case.
Surgery case.
Surgery case. After the surgery, around 3 months or later, I checked by the endoscopy.
Yes.
And if there's a recurrence, in that case, it needs biologics.
Yes. And after you initiate biologics, then when do you perform enteroscopy, balloon endoscopy?
For generally, I checked by biomarkers.
Okay.
Then biomarkers are not good. In that case, I confirm the recurrence by endoscopy Or
Yes.
sometimes I use MR and MRI.
Oh, I see. Okay. I usually perform balloon endoscopy in 6 months to check the effectiveness of the treatment. If I change the treatment or start a new treatment, then I check the mucosal healing in 6 months. But you first use biomarker and MRI. And do you use capsule endoscopy for the follow-up as well?
Capsule endoscopy is very, very useful. I agree. But
Yes.
This is my only my opinion. I suffered some capsule retentions.
Oh.
So that's why I actually I rather use enteroscopy. Not so many cases. But capsule endoscopy is very useful especially for detailed observation of the mucosa. So capsule endoscopy is also very important device, I think.
Okay, I agree. But did you experience retention even after you used the patency capsule or without using patency capsule?
As for patency capsules, for me, no problems. But in some reports, patency capsule itself caused some obstruction. So rather, ordinary capsule is very round and soft. So it is very rare cause obstruction capsule itself. Rather, patency capsule is more often for cause obstruction. So it is.
You don't like patency capsule.
It is it needs.
Yes, yes, I understand. Capsule endoscope can cause retention, but not obstruction. But right. The patency capsule, not only retention, but obstruction. Patency capsule can cause obstruction. That's your opinion.
It's very rare, but
still
not zero.
Okay. Thank you very much for your talk. Okay, let's move to the next speaker. Next speaker is Professor Evgeny Fedorov from Russia. He will give us a talk about diagnostics and treatment of small intestinal bleeding. I'd like to introduce Dr. Evgeny Fedorov is professor of the Department of Abdominal Surgery, Gastroenterology and Digestive Endoscopy at the NI Pirogov, Russian Medical Research Medical University, and clinical head of the Department of Endoscopy and Endoscopic Surgery at Moscow University Hospital number 31. He is the advisor to the Scientific and Practical Council of the Ministry of Health of Russia, the current vice president of the Russian Endoscopy Society, and a member of several international committees and scientific societies. Professor Fedorov received his medical degree from the Pigolov's National Medical Institute in 1981. He completed his surgical endoscopy residencies at Moscow University Hospital number 31 and received diplomas in surgery and digestive endoscopy from the Russian Medical Board. And Professor Fedorov has published more than 180 scientific articles and several books in the area of endoscopy, and is a consultant and reviewer for several surgical, gastroenterology, and endoscopy journals. Professor Fedorov's principal research interests include introduction and evaluation of new interventional endoscopic methods such as ESD, POEM, and STAR, clinical utility of therapeutic endoscopic retrograde cholangiopancreatography, ERCP, enteroscopy and colonoscopy clinical intervention trials. Okay, and Professor Fedorov will give us a talk about diagnosis and treatment of small intestinal bleeding. Professor Fedorov, please.
Thank you very much, Yamamoto-sensei, for your kind introduction. And dear colleagues, dear friends, it's really a great pleasure and great honor to be the part of the Tokyolive and to be with you on this day and share some lessons from our patients, from our clinical cases about the diagnostics and treatment of small intestinal bleeding. This year, we celebrate 20 years of first introduction of video capsule endoscopy in the clinical practice, and at the same time, the innovation of and innovative work of our moderator, Yamamoto-sensei, who investigates the double balloon enteroscope. But nevertheless, diagnosis of small intestinal bleeding, which accounts for up to 5–10% among all patients with gastrointestinal bleeding, has remained an actual problem for many, many years. And as you know, we have two, let's say, slightly different types of small intestinal bleeding. Sometimes we have got patients with overt GI bleeding. Sometimes we have patients with unexplained iron deficiency anemia, and we call it occult GI bleeding. Before the introduction of video capsule endoscopy and balloon-assisted enteroscopy to the clinical practice, both overt and occult GI bleeding was called obscure gastrointestinal bleeding when upper and lower gastrointestinal endoscopy that does not identify the source of bleeding. But the use of video capsule and balloon-assisted enteroscopy techniques in clinical practice really demonstrated high efficiency and diagnostic value, 90–10% for efficiency and 80% for diagnostic value in diagnosing the source of small intestinal bleeding. And in nowadays, it's a strong trend to call the obscure GI bleeding only when no source of bleeding identified on small bowel evaluation tube. And if we look to our own numbers about the localization of sources of bleeding after examination of small bowel using enteroscopy methods, you can see that we find the actual source of bleeding in small intestine in 73%, in upper and lower GI tract in 9.5%, after initially missed lesions of upper and lower GI tract, and we do not identify the source of bleeding in 17% of patients. And that's true that obscure GI bleeding in nowadays is reserved for persistent or recurrent bleeding in patients with normal EGD, normal colonoscopy, and normal small bowel enteroscopy. Speaking about the sources of small intestinal bleeding, it's interesting that we have geographic differences in distribution of sources of small intestinal bleeding according to region. In the United States, in Europe, the gold medal and the first place is vascular lesions, from 30 to 80%, while inflammation and tumors are on the third place. And in Asia, inflammation on the first place, it's 41 to 53%. As you know, Moscow and our country is somewhere between Asia and Europe. And you can see that also the distribution of sources of bleeding is more or less in the middle of between Europe and Asia. On the first place, at least in our material, is the vascular malformations, 39.6%. Neoplastic lesions on the second place, 38.5%, and inflammatory lesions, 26 and 6%. But at the same time, I would like to emphasize that the sources of occult small intestinal bleeding where the inflammatory lesions, even in our population, is on the first place, is different from the sources of overt small intestinal bleeding. And also in our population, like in Europe or in the United States, vascular lesions is the main source of overt small intestinal bleeding. For the last years, we have got many diagnostic algorithms of obscure GI bleeding from different societies, from Europe, from the United States, and finally in 2017 from Japan. Of course, it's not enough time to look through all these diagnostic algorithms, because it's not very easy to realize it in the short lecture. But we can underline the several very important points. First of all algorithm recommended to repeat upper and lower GI endoscopy if you are not satisfied with the previous one. And of course, it's strong trend to divide patients for so-called actively bleeding, or as we call it, overt bleeding, and for the patients who had a iron deficiency anemia, and we suspect that the cause of iron deficiency anemia somewhere in the small bowel or through the GI tract. And let us see the actual clinical presentation, clinical cases of occult GI bleeding as an ID course. And from this patient, from these interesting cases, we can learn more, and we can add probably something to the algorithm of diagnosis of such kind of bleeding. Once more, I would like to repeat that in our material, in our population, the sources of occult small intestinal bleeding, the first place is inflammatory lesions, on this second place neoplastic lesions, and third place vascular lesions. And let us see the clinical examples of all these sources. 57-year-old woman complained for weakness for several months. Hemoglobin 65 gram per liter. From analysis, we realized that she was iterated, can you imagine, 30 years ago for invagination of the ideal hemangioma, and afterwards no complaints at all for 30 years. And of course, we start to try to find the possible source of bleeding or iron deficiency anemia from EGD and colonoscopy. They were negative, and we suspect occult small intestinal bleeding. During the video capsule endoscopy, we have a suspicion for anastomotic ulcer on the left side of the slide, and during balloon-assisted enteroscopy, we really find the chronic anastomotic ulcer in the enteral anastomosis. So we made the diagnosis of occult small intestinal bleeding from anastomotic ulcer, but conservative treatment, unfortunately, for 6 months was ineffective. Our gastroenterologists take care about this patient, and we have to perform laparotomy, resection of anastomotic section of the small intestine, and you can enjoy the ulcer in the area of enteral anastomosis after the operation. And it's interesting findings in histology. For example, we find the suture material at the base of the ulcer, and probably it's one of the causes which 30 years after the first operation finally caused this ulceration and small intestinal bleeding. No signs of malignancy during the histological examination. Another patient, 56 years old, also iron deficiency anemia, suspicion for occult small intestinal bleeding, and during video capsule enteroscopy as the first step, we have a suspicion for the tumor and balloon-assisted enteroscopy at the second step reveal our diagnosis, and we found the malignancy, and finally it was the resection of an area of the jejunum with a tumor with the imposition of a side-to-side anastomosis, and it was moderately differentiated adenocarcinoma of the jejunum. And relatively rare case of multiply venous malformation, so-called blue rubber bleb nevus syndrome, as a cause of iron deficiency anemia and occult recurrent gastrointestinal bleeding. This patient came to us at the age of 31 years, and her complaint is weakness. From analysis, we realized that from the age of 10, she had a severe anemia up to 50 grams per liter, corrected with iron supplement. No pathological changes on EGD, colonoscopy at place of her residency, not in Moscow, single hemangioma of sigmoid colon, as she was consulted by hematologist. Under the general examination, we find the multiplied blebs on her feet and wrist, and scintigraphy with labeled red blood cells find the fixation point of the indicator in projection of the small bowel, increased in size, and suspicion of intestinal bleeding. During video capsule endoscopy and after that, the balloon-assisted enteroscopy, we use single balloon enteroscope from Olympus, Japan. We found the several blebs, so-called bleb nevus, rubber blue nevus, and some signs of bleeding, as you see in during the balloon-assisted enteroscopy, we reveal the same rubber blue blebs as a source of her iron deficiency anemia. And we try to find a way to treat this patient endoscopically through the balloon-assisted enteroscope, trying to put the nylon ligature to the base of this, the biggest bleb. But unfortunately, we failed because absence of malformation peduncle, surface density and irregularity of the surface, and also some signs of extra organic growth or malformation. And during surgery, we really find the multiply venous malformations, most of which prolapse through the serosa. And we laparoscopically assisted extracorporeal resection of small bowel with the side-to-side anastomosis. And here you can enjoy the resected segments of small bowel with these malformations. And in histological examination, it was dilated vessels with blood, and the Bean syndrome or blue rubber nerve syndrome was revealed. Fortunately, post-operative period was uneventful, and even just in 1 month after surgery, no complaints, and hemoglobin first in her last 20 years was 100 grams per liter. Now let's change to overt GI bleeding. Overt GI bleeding, on the first place, it's a vascular lesions, also in our population. But before talking about the video capsule or balloon-assisted enteroscopy, we have to realize that sometimes we have such kind of bleeding as hematosuchus pancreaticus, as in this case due to pseudoaneurysm of the splenic artery in a patient with chronic pancreatitis. And of course, we add the MRI or we add CT angiography to all algorithm for G suspicion for small bowel bleeding. And you can enjoy during the operation, it was the elective surgery for chronic pancreatitis, and you can enjoy the gentle coils inside the pseudo-aneurysm of the splenic artery in the dilated main pancreatic duct in the tail of the pancreas. Or sometimes we even don't need to use the balloon-assisted enteroscopy. We can just go with our regular scope if we suspect something in the third part of duodenum or in the first part of the jejunum just beyond the ligament arteries. This patient, elderly patient, came to us and have three repeated recurrent bleeding during staying at the hospital, and finally during the, let's say, extended EGD, we find the aorta duodenal fistula, and of course the treatment was emergency surgery because this pathology was not amenable to be treated endoscopically or radiology, and during the emergency surgery we found and confirmed the aorta duodenal fistula, as you can see in this slide. Or sometimes we can also find the fistula between the infrarenal abdominal aorta and the jejunum below the trias ligament, and also it's an indication for surgery because this pathology is not amenable to be treated endoscopically. It's interesting, but it's still some cases of so-called vicious circle when the patient, even the patient with the 3 episodes of overt bleeding, and actually it was the patient 18 years old, she had got the first case of overt bleeding with hematochezia 2 years before admission to our hospital, with the drop of hemoglobin to 70 gram per liter, and on emergency EGD and colonoscopy, the source of the overt bleeding was not found. 1.5 years later, she has another overt bleeding and second hospitalization with the hemoglobin 60 gram per liter, and emergency EGD, colonoscopy, and MRI. Also, the source of the overt bleeding was not found. And finally, she came to us after the 1 month after the third episode of overt bleeding, and we performed video capsule enteroscopy, found the small, relatively small, really subepithelial lesion of the ileum in the source of the small intestinal bleeding, and perform laparoscopic resection of the ileum bearing the tumor, and also made the measurement of the length of the small intestine and the distance from the ileocecal valve to the tumor in order to, here you can see the steps of laparoscopic resection of this, completely laparoscopic resection of this tumor. And finally, we compare the results of EC10 progress bar, ECT10 time, and measurement during laparoscopic surgery, and the error of localization for this tumor was only 3.2%. And the resected specimen with the tumor, you can see, really small, 15 millimeter tumor, and it was not the GIST, it was the leiomyoma of the small intestine with the index of proliferative activity, Ki, less than 1%. And the postoperative period for this patient was unevented, and within 5 years, clinically calm, no repeated bleeding. She gained her weight, and hemoglobin now is normal. And another vicious circle, but only one episode of overt bleeding with hematochezia, patient of 26 years old, urgent hospitalization in the place of his residency, emergency EGD, no source of bleeding, emergency colonoscopy, no source of bleeding, abdominal ultrasound without pathology, CT scan of the abdominal thickening of the walls of the initial portions of the jejunum, and the patient was sent to us for video capsule enteroscopy, where we found really interesting findings, we think that it was the Meckel's diverticulum with the ulceration, and you can see here the ulceration of at the base of the diverticulum. And at the same time, we found the satellite hole inside the metal diverticulum. That's why we decided to perform single balloon transanal enteroscopy to realize probably it's fistula or something else. And during this transanal enteroscopy, we of course found the entrance to the diverticulum itself, found the actual source of bleeding, the ulceration here, and using the single balloon enteroscopy, enter to the diverticulum and find here the hole, and try to penetrate beyond this hole, and found the second chamber of Meckel diverticulum. That's why we performed the laparoscopic resection of a portion of the ileum bearing Meckel's diverticulum with the formation of the side-to-side completely intracorporeal anastomosis, and remove the Meckel's diverticulum through the laparoscopic approach on the right side. And here you can see we found a way to measure the distance from the ileocecal valve to the diverticulum using the thread, and we put the thread on the peritoneal wall, and then using the peritoneal wall as a measure device, we step by step measure the length of the small bowel, and after the resection of the diverticulum, we remove it. You will see it just now in the special container through the small incision in the right side, and close it with the thread and needle. And the wall of the resected Meckel's diverticulum, all layers of the intestinal wall was on place, and the actual cause of the formation of ulceration was the heterotopia of the gastric mucosa at the base of Meckel's diverticulum. The postoperative period was uneventful, and within 6 years, patient is clinically calm with no repeated bleeding. Talking about the overall therapeutic methods for diagnose small intestinal bleeding, we can enjoy that our approach using the capsule endoscopy or balloon assisted enteroscopy made it possible to perform conservative treatment and observation for approximately half of all our patients, mainly with the small erosions, ulcers, or and so on. Of course, in a quarter of patients, we can use endoscopic treatment. It's mainly argon plasma coagulation or clipping of vascular malformations and removal of benign neoplasms, mainly multiply hamartomas in Page-Jagger syndrome. But 27.8% of patients certainly need surgical treatment, and we working in the surgical department and doing surgical operations ourselves, of course, remove the diverticulum or tumors using the mainly laparoscopic approach. And in this case, enteroscopy gives us opportunity not to perform laparotomy and use the minimally invasive surgery. So, dear colleagues, dear Yamamoto-sensei, our conclusion that the use of video capsule endoscopy and balloon-assisted enteroscopy in clinical practice really changed the algorithm of diagnosis and treatment of small intestinal bleeding, made it possible to perform an effective examination of the small intestine and identify the source of bleeding in 83.8% of patients, of which localization in the small intestine in 88.5%, and in the upper and lower gastrointestinal tract in the rest 11.5%. And determine the rational tactics of patient management, conservative treatment in 48.1% of patients, endoscopic treatment in 24%, and surgical treatment in 27.8% of patients. Thank you very much for your kind attention.
Thank you. Thank you very much. Thank you very much for your very nice talk, Professor Fedorov. And thank you for showing us very interesting cases. And I totally agree with you that development of capsule endoscopy and balloon-assisted enteroscopy, and we can make a diagnosis of small intestinal bleeding, and we can select a proper treatment of choice, such as conservative treatment and endoscopic treatment. And even when you have to choose surgical treatment, you can select minimally invasive treatment such as laparoscopic resection.
I agree with the big advantage of these techniques. That's true. And it's interesting, Yamamoto-sensei, isn't it, that every year we add something new to the diagnostic algorithm, according to newcomers, according to the new lessons from our patients. But step by step, it seems to me we have to organize not algorithm for Japan or algorithm for United States or for Russia, but more or less general algorithm of diagnosis and treatment of small intestinal bleeding for everyone. And we are near to this algorithm, it seems to me.
Yes, we are still improving even after 20 years, already 20 years after development of capsule and balloon-assisted enteroscopy, but still we are finding new things and improving our strategy to investigate the small intestinal diseases.
Yeah. And I don't know, agree you with me or not, but CT angiography, especially for overt, really massive bleeding, is playing more and more important role as a starting point. Agree?
Yes, I totally agree with you. That's the reason why in Japanese guideline, the enhanced CT is the first choice after the upper and lower endoscopy. Yeah, that is. I totally agree with you.
Thank you.
Okay, I have a specific question about your one case. What is the long-term prognosis after the surgical resection of the blue rubber bread never syndrome?
Sorry, I interrupt you.
Do they develop a new lesions even after surgical resection, or it's rare?
First of all, it's a rare condition, so not so many cases around the world.
Right.
We are following this patient for 5 years now, and we do not see formation of new angioectasis, malformation, as it sometimes happens in patients with the actual angioectasias, especially the older one. According to the literature, we do not see the cases where the colleagues explain that, for example, they find something new. It seems to me that they find maybe missed lesions or not removed lesions, but not the new one, because it's hereditary condition, and it seems to me we should not expect the new one. But at least for our patient, we are in contact, and we will follow her medical conditions, and will present her in few years to answer better to better answer to your question.
Okay, thank you. Thank you for good information. Okay, anyway, another question. Is motorized spiral enteroscopy available in Russia now or not yet?
Unfortunately not. We are waiting. We even, some of our colleagues spent some time in Belgium to learn this technique. I personally helped to Torsten Beiner in live case when he performed spiral enteroscopy. But unfortunately, spiral enteroscopy is now in the under the registration, but not commercially available at the moment.
Okay, will it be introduced within 1 year or so in Russia?
Yeah, according to the information from the Olympus company, we are waiting for the maybe on this autumn it will be launched for the clinical.
Probably about the same in Japan. It's about the same timing.
Yeah. Really? I think you already work with this equipment.
It's not commercially available yet in Japan as well.
And by the way, Yamamoto Sensei,
yes?
I always repeat your words to a representative of Olympus company and Fujifilm company in Russia, that Yamamoto Sensei give me the good advice to have a short enteroscope for ERCP procedures. But unfortunately, we also still have not commercially available short balloon-assisted enteroscope for ERCP.
Really?
Yes.
Oh, I didn't know that.
Unfortunately.
Really? In Japan, we have both the short single balloon and double balloon.
I know. I asked you at least to sell it for us personally. I mean,
yeah, it's very useful.
I know. That's why I explained it to you.
Okay. Yeah, Professor Otsuka, do you have any comment or anything to discuss together?
Well, thank you for the nice presentation for Professor Fedorov. So they are the very orthodox way. So stepwise capsule endoscopy and surgery and the treatment of success. It is very nice and very educational lecture. Thank you very much.
Thank you very much, Dr. Sensei. Thank you.
Good.
We also have our first lessons of single balloon enteroscopy in Yokohama from you, if you remember. Thank you very much.
Yeah, Professor Otsuka, what is the most important thing you want to emphasize for the audience when they start performing single balloon enteroscopy for the evaluation of Crohn's disease patients, the small intestinal diseases? Yes.
As for Crohn's disease, around 70% of Crohn's disease patients have the small bowel lesions. And in many cases, it was missed. So of course, I prefer endoscopy, but also capsule endoscopy or MRI. Even CT is okay. First, the most important point is Crohn's disease patient. Many Crohn's disease patients have small bowel lesions. So then what kind of modalities you can use? Then you choose the modalities and assess the small bowel. But the first point is there are small bowel regions exist. Don't forget small bowel, I think.
Yes, it's very important because sometimes even with active small intestinal lesions, they are asymptomatic. So even asymptomatic clinically remission patients, still they have small intestinal lesions. So we should not forget that, right?
Right.
Yes, I totally agree with you.
Thank you.
Okay.
Me too.
You too. Oh, good.
Thank you.
Okay, nice discussion. Thank you very much for nice presentation, both Professor Otsuka and Professor Fedorov. Thank you very much.
Thank you very much for your kind moderation and
Thank
interesting.
you.
Goodbye.
Thank you. See you.